So let's build on this summary list of recommendations. Let's just leave it right there because I think it's a great start. As we as a roundtable then reflect on what we've heard about today at this workshop, I'd like each of you to offer, if you can, a couple of key points that you've gleaned from today's workshop briefly. We've got a lot of people and a little time. We always have a premium on time. So who's ready to start? Go ahead, Cindy.
Okay, Cindy, right. I'm thinking of culture with, culture eats strategy every day. What do we need? What do we have in our armament, our set of tools to try and move this issue in organizations? So some of the things that I heard today is upstream, starting even with medical education, continuing education, IRB education in the case of research. Looking at legislation and regulation. So we heard about the provider standard, which I thought was in a majority of the states, but thinking that might not be the best standard. Alicia brought up the language access issues, which, I think most of us were horrified to hear that you could have your leg cut off when you didn't speak English and nobody had interpreted that for you. I also think malpractice and lawsuits or the threats thereof is a potential lever, and I want to get a list from Chris of the most salient cases in that area before he leaves. We talked a wee bit about patient empowerment and trying to work that end of the equation. There's also, we all know when we talk about culture, we also talk about leadership and how can we get leadership to drink the Kool-Aid, and are there other things that leadership care about that we can hook this to, whether it's patient-centered care or shared decision-making or other initiatives that are priorities in that organization that you can hang this on. Looking at hardwiring this. So we talked about it requiring sustained attention and the fact that, forms could help drive some of this, communication tools, supervision, documentation, what are the structural processes. All of those levers are for change are going to need to be wielded to get anywhere on this difficult issue.
It's a good starter list. Kim?
Hi, I don't think I have introduced myself yet. So Kim Parson from Humana. So I just wanted to say thank you to all the speakers and their efforts and research and shining a light on this topic. And your contributions in this forum will bring focused attention on what we know to be a gap for patients. What we heard is that what we currently have is not effective for any person, no matter their health literacy level. There have been many attempts at making the processes and documents patient-friendly, and those efforts should be applauded and their learning should be applied in future design. Today's discussion is a really good starting point for continued exploration of the impact of rules and regulations on organizations' abilities to act in a health-literate manner. At the end of the day, patients, caregivers, and providers are most impacted by the unintended complexity that results from the intended protections from the 51 state departments of insurance and multiple regulations by federal agencies. Though the challenge is great, we have examples of previous successes, and opportunity exists to create a best practice around informed consent by using simplicity and human-centered design principles. Using human-centered design is to design for the end user in mind. By co-creating with patients who have experienced the informed consent process and with people who are potential participants in the process, we will discover their needs and how they want those needs to be met. The results will be a more knowledgeable, willing, and engaged end user while achieving the goals of those seeking consent.
So that's excellent, and reminds me that probably the next step from this conversation is actually more of a conversation around determining needs and wants and design principles, actually, this is a terrific start along that journey. Lori?
I'm thinking about, often I get inspiration from sources outside of healthcare, and I'm thinking in summary, I'm a fan of an author called Daniel Pink, and he wrote a few years back a book called A Whole New Mind. And he talked about in this age of information overload, we can certainly put a lot of energy around creating efficiencies and looking for ways to streamline, and we can even outsource automation. But one thing we can never outsource is empathy. So with that in mind, I'm realizing that with all of the discussion we had today, and it was excellent discussion, but nothing replaces human engagement, and how that will never be outside of the of our discussion, or should never be. If we're really looking to transform informed consent to informed choice, we can't underestimate the power of human engagement. And that would be certainly required, if that patient engagement is required to build the trust, to educate and empower patients so that true shared decision-making can take place.
A lot of eloquence on that side of the room over here. So, Wilma?
Well, I have Lindsay's tent up because she
I thought you
trusted
might.
me. She trusted me with some comments. So I'm going to give my comments and then I'll follow up with hers. So I just also wanted to echo what a wonderful workshops we had today. And I also appreciate the recommendations as well, in addition to adding the cultural and linguistic pieces to the informed consent, because let me tell you, as an interpreter, that just makes my role so much more interesting when I'm on the units. I'm just saying. And then again, because a lot of our patients who are immigrant or refugee, we don't live in a world of HIPAA, living wills, and advance directives. And there might not be a linguistic equivalent for some of these terms that will hold up in a court of law if and when they get there. So one of the things that I had asked a question earlier about visually impaired, and I was really pleased with the response that was presented, because one of the things that when we work with our visually impaired patients is that whomever is conveying that information really needs to be aware of the tone of their voice and the fluctuations. That is extremely important because that can influence decisions. The other piece when we're working with our deaf and hard of hearing communities, simply just handing the visual document to that individual is working under the assumption that they are literate in English and that there isn't an issue of comprehension. So I think we need to keep that in mind. And then the caretaker, regardless of level of education, when it becomes somebody that is a loved one to you, working under the assumption that that individual has the foresight to ask certain questions when they have an emotional connection to it. So that's another piece I think we need to keep in mind. I think that education on so many levels is what I have heard from the workshop today. And then I'm going to take it back to, as we say in Spanish, I'm praying to my own saint. Educating about what the role of the translator is, which is the written communication. When providers use the terms interchangeably, that's like, nails on a chalkboard for me. And the interpreting is the oral communication. So I think there needs to be education on how to appropriately utilize an interpreter, because I, as an interpreter, when I have that legal document in front of me, and God help me if I misspeak, I can be subpoenaed just like anyone else. And then from the community perspective, working with the community research projects, I think the IRB in academia also needs to have some insight as to what would resonate with the community, because the community remembers. And so now I'm going to switch hats and try to be Dr. Lindsay Robinson, who's president of the California Dental Association. All right. So she said that dentistry was not really represented, and part of the problem is that dentistry is not engaging in informed consent. And this goes back to the why we ought to care and why they should be engaged. She also added that some additional reasons for this is because much of the services that are provided are seen as elective, and so the perception is that the risk is low. Also, it has the perception of being a less litigious having less litigious activity in dental versus medicine. And there's also an inherent conflict of interest since most of the services are provided by dentists who are in private business, and they're the ones making the decisions. Thank you.
So thank you for your comment, and thank you for relaying some of Lindsay's comments as well. Rob?
What I'm thinking about right now is a couple of topics that would be perhaps worthy to address or consider. Certainly, their interest to me. First, the law schools that I admire, and that is not my background, have within them departments of mediation, where the goal is not to train is not necessarily to train attorneys who represent a client or even a group of clients. The purpose of mediation is, and not necessarily to always reach consensus when there are issues. Their job is to literally think of a higher standard or goal besides the needs of the people who are in dispute, and think if there's something broader, more socially important or vital that we can reach some sort of agreement that is vital and use that as a linchpin or a foundation in order to come to some sort of agreement. It occurred to me when I listened to some of the discussion today, there is a vital role of mediation in establishing better cooperation and collegiality among the stakeholders involved in the informed consent process. I haven't heard that mentioned all day. And I wonder if we get some mediators interested in this topic, we might actually, I think bottom line is I think legal community in some respects is seen as part of the problem. I don't see it that way. I see them potentially as part of the solution. But I think we're not talking to the right lawyers, okay? And I'd say we talk to those people who are experts in mediation and looking for higher standards and don't see the idea of my job, and the job of a mediator is not protecting my particular one client from harm. It's to look for a broader social purpose that we can come together on. Also, the other thing that comes to my mind is that individual, cultural, clinical, ethical, social, public health, and community harm that stems from dense language or excessive complexity in consent and other clinical forms. We don't have a J'accuse paper that I know of, a document that outlines all the harms that come, okay, from excessive complexity. We don't have a way of outlining those issues to people so that anybody who is interested in those things will immediately see, I'm involved in a process here that causes just enormous harm, and I never stepped back to think about what the range and degree of harms are. Again, I wouldn't have known until today that we might ask for something like that, but nevertheless, and I'll certainly, it's not in PubMed, but I'll take a look at some of the literature to see if there is something like that, but I've never seen it. But aren't we talking about something which causes enormous harm? And can't we find people who can better outline the range of that harm and from a very ethical perspective and across the range demonstrate what that is?
Thank you. And I just will add to your comment on two counts. One, Chris Trudeau, thank you so much for being with us again. But, I think what you said was that the way that the legal professions change is through the judges. And you said that more than once,
I said that at least once.
Yeah,
right.
at least more than once. I would challenge us to figure out other more shorter term mechanisms, I think, for change. And I think it would be an opportunity for us to actually, with some of your colleagues, to engage in some conversation about what those mechanisms might be. And I think that might be actually something that would flow from this. The second comment that you made, Rob, that I want to associate myself with and support is your suggestion. I hadn't thought of it till you said it. The J'accuse, I accuse document around complexity. I can't tell you, based on my experience here as chair of the Roundtable, in another conversation that's not health literacy focused, how much trouble I've had making that point in that conversation that complexity is an issue around health literacy. We don't have that really put together. And I think it applies here in this conversation around consent. And that's something we need to work on so I really personally appreciate those 2 points at least. Katina.
Thank you. I don't think I've introduced myself today either. I'm Katina O'Leary from Health Literacy Missouri, and my closing comments really quite brief. I just want to go back to the morning sessions where we started with the paper. We spent most of the afternoon most of the day actually talking about a pretty narrow path of what is informed consent and why does this matter. But the commission paper was much more broad. There was a focus, in fact, they said one of the major gaps was in community research, the fact that we don't know much at all about health literacy and informed consent and community-based research. And that's so important. The risk is so high. The risk is so high, not just for the treatments that are offered, the clinical trials, all the things that are offered in the community, but also the opportunity to completely demolish trust and ruin the whole enterprise. So I just want to be careful. I think it's really easy to focus on clinical trials in hospital settings where we can talk about death, and that's certainly the thing that worries people the most is that people are going to die because of this. But the real risk to many people in the community is much more simple. We demolish their trust. We change understanding. We make them feel like they're not part of this conversation. So all of these afternoon conversations about who gets to decide, who gets to have the conversation, what is shared decision making, who gets to lead that conversation in shared decision making, I think that's really important. I feel happy that we got a little bit closer to that this afternoon, but I think we didn't even really scratch the tip of the iceberg here, and so I hope that we can continue on.
Thank you for that reminder. Bernard?
Bernard Dreyer, pediatrician, New York City. So the first thing I want to focus on is which we heard about today, is the issue of language. We are nowhere near where we should be regarding providing appropriate interpretation of any kind to what is really a growing and huge population of people who are limited English proficiency. And I think it seems to me that something important has to come out of this session about that, because this is a prime example of when you really need people to understand. And language, when I give talks on health literacy, I usually say the first 10 principles of health literacy are language, et cetera. So it just seems obvious, but that we haven't moved very far on that issue. Secondly, several times we mentioned patients or families or partnerships with them, and I think that's a very important issue in a variety of ways. We need to have their voice as part of this. We also need to, just reflecting on what Michael said, we need to empower them and have them understand how important this is. I just spent 2 days with groups of parents in a research study looking at family-centered rounds, and they had all these issues about the care of their children in the hospital. They never once mentioned informed consent, but they can be motivated. Thirdly, I was really, regarding the complexity issue, I was really impressed with the tension between the obvious need to make this simple and understandable, and at the same time the tension with all hearing from other people but there are specific things we do need to tell them, and when you start adding all those things up, it ends up, even if it's in clear language, being pretty complex. So the tension between those two things is something I hadn't thought about before today, and I think it's something we need to think about better. And finally, I just want to mention 2 other issues which we touched on but didn't talk about, which I think are critical. And one is numeracy. A lot of this has to do with numeracy. We had a whole workshop on it, but the principles of numeracy, I think, are when you think about just the concept of risk, it's all about numeracy. And so how do we integrate what we've learned or what we'd like to do about numeracy into the informed consent process and culture? And I mean people's culture rather than our own medical culture. I've been impressed every time I've tried to communicate with somebody from another culture I've been totally off base often about what their understanding is versus what my understanding is. So health beliefs and those are two things we actually didn't talk too much about, but I think need to be part of the conversation.
Very good reminders. I think the patient empowerment, patient participation is a very good, very important point in my view. And but if we end just there, and we've emphasized that more toward the end of the day, we're sort of missing the boat a little bit, in my opinion. Just to add to your comment, I think we also need to use data. We need to systematically understand the needs of our patients, both in the aggregate as well as individually. And we need to develop approaches to respond to those systematically, reliably, every single time by many multiple providers. And those modern techniques need to complement the participation and engagement that we have of patients in our process. So I would just add that to your comment, if I may. Bernie?
Yes, that point about data is extremely important. We probably have not emphasized that at all during the day. And let me just thank you for bringing that back to our attention. Two things that I would like to address. One is, as I listened most of the day, this is really, and we may have said this before, this is nearly, not really about patient education. It's really an issue, as I see it and as I've listened, about a cultural change for researchers, for clinicians, and other members of the healthcare team. And we perhaps need to explore exactly what's been done in that area, because maybe there is more that's been done than we appreciate. But from my sense, as being involved as chairman of an IRB for a decade or so, that's where a lot of the effort has to be placed in terms of the researchers, clinicians, or whatever that are presenting to the IRB and their understanding. And we, as this organization, should try to be the change agent and maybe the catalyst going forward to make some of this happen. Number two is to, as I see it, is to reinforce Katina's comments, because that's where I was going to go anyway. And that is about the lack of guidelines and toolkits for health-literate informed consent in community-based research. It would seem to me, if we look back a decade from now, as to where most of the research is going to be accomplished, I think community-based research, for reasons of population health, for reasons of defining healthy living, it's all going to be, or not all, but a lot of it is going to be in the community. And what exists in the community that we know about is clearly cultural disparities, linguistic disparities, socioeconomic differences, all the things that we need to pay attention to when it comes not only to research, but to how we deliver care in that arena. So if we talk about shared decision-making, particularly between the family and the participant, the patient, I think the community is the area where that needs emphasis more than anything else in the hospital environment. So I'm thinking that both those things we could take as a charge for the future, both the area of lack of guidelines and toolkits for health-literate informed consent, and the fact that this is really not only patient education. It really requires a cultural shift in the area of the researcher and the clinician, the healthcare team.
Really appreciate that reminder. Jim, I missed you.
So I want to give kudos to the planners for putting together a really great panel, or several panels, to look at this issue from a well-rounded perspective. And also wanted to offer a counterpoint. I was texting with a former student of mine who's now in med school, and he happens to be doing a rotation with the GI doc, whose process of consent goes like this. If you sign the form, nothing bad happens. So, and I said, oh, you're learning from the best, right? So, obviously, we've got a long way to go in a lot of different areas. And it sort of underscores the point that, yeah, some of this intervention needs to start a lot earlier. But I think what I want to underscore, similar to what Bernard was saying, was the issue of language. One of the, in the commission paper, one of the things that they recognize is something that is obvious, but I think because it's obvious, we often skip over it, and that is that translation does not equal comprehension. You know, and a lot of what we've been talking about is informed consent in English does not equal translation, does not equal comprehension, right? So, you know, translating it is not the end of the intervention. It's really just the beginning. And so I'm glad that we've created some space for that discussion and to continue to, hope we continue to have that discussion. Now, one of the things, of course, working for HRSA, we are quite interested in primary care and primary care doctors and the system of primary care. So I do appreciate the sensitivity to the work that they have to do, and not just involving them, but involving all of the people who work in that healthcare system. So it's not just the doctor's responsibility, but other people who are along that care continuum. And because community health centers are, you know, by law consumer focused, and their boards have to have consumers on them. I think it's an opportunity, and I think it's one of the things I'll look into after this is how they are innovating or being challenged by this issue of informed consent. And of course, you know, one of the opportunities and challenges that we continue to come up against is the Affordable Care Act, and with so many more people enrolled, we've got so many more people to consent. So to use that word, I don't use that verb. That's the first time I've used it like that since I'm not a clinician, but that's something definitely to keep in mind. The last thing I'll mention is, you know, one of the things that those of us who are educated and have degrees on, we're used to words, but I think a lot of what's happening is there's sort of this informatics or excuse me, infographics and things like that, and use of pictures. And I think in thinking about how to design forms and how to teach, I think that's definitely something that deserves some more exploration.
Thank you very much. I'm going to go right over here to Steve.
Yeah, thanks. Steve Rush, United Health Group. First, I want to thank the speakers and the planning committee and the staff for putting together a really great program. The commission paper was really outstanding. A couple of thoughts came to mind, and today's presentations reminded me that this is a process and not all about the form. And thinking about all that has to go into that process. There were several concepts that repeated themselves several times. One was from persuasion to pedagogy, focus on the patient or the consumer and their values, and we tend to explain before we understand the patient. And that really was very, very helpful and informative to remind me about things. I think Chris Trudeau's presentation was tremendous. I liked it for several reasons. Number one, I've seen his other presentation, which talks about the value of plain language. And I've also saw the presentation today. And I think to a certain extent, we need to be aware of all the levers that we have available to us in terms of culture change. One last thing, and that was one size doesn't fit all for informed consent, but we also need to be mindful of the fact that one size doesn't fit all for shared decision making. And thank you.
Terrific. Winston?
Again, I want to thank the organizers as well as all of our speakers today. It was actually a very complex day, and dealing with some very thorny issues. But then I thought that it really boiled down to the question of how we look at informed consent. And to me, informed consent boils down to two almost conflicting dynamics. One is protection, and the other one is empowerment. And taken from an institutional point of view, certainly there's protection of the organization, of the individual, the provider, and empowerment to be able to do the right kind of thing, ostensibly for the benefit of the patient. And that same dynamic is also apparent with regards to patient and family, protecting the patient from insult, injury, et cetera, but also empowerment to make the right kinds of decisions for themselves and their family. And it seems that these two facets of informed consent, there's a very thin line between what constitutes protection and empowerment. And to that extent, I think Ken's last comment here with regards to having the patient voice be the definitive voice with regards to looking at how the balance between protection and empowerment is achieved is a really important one, which we unfortunately didn't have anyone per se that could speak from that, that perspective. The final point too, with regards to, I think, Michael's comment about how do we move the agenda, or maybe your comment, George, with regards to how do we move the agenda, we need to press this more, I think, in terms of a health equity and health disparities perspective. As was noted by Dr. Fernandez, there is a disproportionate burden of how this really is activated among communities. And I think about the way that this could really be pushed forward is around trying to capture what kind of suffering is actually occurring because of our lack of ability to address informed consent. And I think suffering is both an emotional suffering and the turmoil of patients having to deal with unforeseen circumstances and having anxiety with regards to their patient journey. And then obviously the physical suffering that goes along with circumstances that we can't predict, as well as the suffering that's associated with just being ill. And if we really are able to capture that aspect of suffering, I think eventually it translates to how this impacts our system and the resources and how we deploy our system ultimately to dollars. So we have to be able to connect the pieces between the aspect of suffering and how this is a contributor to choking our system in terms of the resources that we attribute to it.
Great, thank you. Michael?
Michael Valera, Institute for Healthcare Advancement. Of course, I echo the kudos for all of the speakers today, the planning committee, excellent job. I think we got a really good, broad representational perspective. I agree that the patient perspective would have been good, but I think that's that's part of our job to bring that in there as well. The one thing I was heartened by today was the emphasis on making informed consent more into a patient-centric process. Would love to see this continue to move from being the kind of the joke, the oxymoron of informed consent, and the issue of this being a checkbox and one more thing that we have to accomplish, and really to transition that into a much more meaningful process, something that's meaningful for the patient. I think that's really my takeaway, is that this needs to get back to what it was originally intended to do, which was to be of something of meaning to the patient, to be a protection for the patient. We need to ask the patients, what do they want, and use that as our baseline and go from there. Some people may, want to really understand what's going on, be informed of their choices, and really have that be a very meaningful, critical conversation. Some people may just make that choice to say, you know what, I trust you, and that's as far as I want to go. It shouldn't be something that we're forcing upon anybody. I like the notion of patient-centered, especially in the panel that talked about some of the multicultural issues. Patient-centered means that we're using all of the arsenal, all of the terminology, and all of the facets of of how we look at patients. That's language, that's culture. How much are they activated and interested in this? What is their cognitive and sensory ability and capability? I just loved the story from Rebecca Sidori talking about, when we talk about people who are passionate and really advocates about this, and we have people who are really marginalized and kind of forgotten about it. And I just loved the story about the patient who is, the elderly patient who's lying there and is non-responsive. And rather than just saying, oh, we asked him and he's non-responsive, it's like, no, we need to go that extra step. Let's understand where that patient is at. Let's take a little bit of extra time. That's, in my mind, that embodies the real spirit of what we need to be doing here with regard to informed consent. There's issues of technical literacy or technological literacy, those who are facing health disparities, unfair health equity situations, literacy, and of course, health literacy. We need to ask our question, who does the informed consent process serve? And as far as I'm concerned, it should be serving the patient. And that's really, when we get back down to that, that's where the nexus of health literacy is all at. We need to communicate on their turf, not on ours.
Andrew? And then we're coming to the end of the line here. We're coming to Laurie and then Ruth. But I am going to open the microphone for those of you who remain in the room. If you have any comments to have, if I have a few minutes, and it looks like I will. So if any of you want to be thinking about that, you should be thinking about that as we hear these last couple comments. Laurie? Or Andrew, I'm sorry.
Sorry.
That would have been very brief, Andrew, but too brief.
I was going to make a joke about taking 15 minutes, but I quickly decided not to. The other bad joke is, what is the correlation with changing the title of your talk? I just don't know, but there's got to be something there. So the worry about the discussion today, to me, is, to be very frank about it, that it's very easy to criticize the informed consent process and form from a perspective that is different from what the process and form were initially designed to do. So wouldn't it be lovely if it was initially designed to protect patients? But the honest truth, and we did hear that, is that it wasn't. It's designed to protect institutions and professionals from lawsuits. So to change the culture, I believe we need to be very direct and upfront about that we are not asking for tweaks to the process. We're asking for a very different process with a very different desired outcome. Anything else, I think people who have the power to make those changes will sort of nod their head and say, how nice for you, and walk away, as they've done for some time, because their priorities are not our priorities. So I think from the very fundamental, Michael was right. It is a cultural shift, and that means a shift more than just in plain language. I really appreciate Katina and Bernard's highlighting community-based research. As I read the commission paper, it didn't, to my read, say that there wasn't good practices in community-based research. It just said there wasn't a lot of research and documentation of them. So I would not be surprised when that research is conducted that, in fact, some of the best practices that people are looking for emerge from that very arena. They're just not highlighted well enough. Clearly, the interpreter issue is a very large issue, and it just points out that there are existing laws that are not being enforced in this area. Having said that, I am convinced that we do know enough to actually push regulations forward a little bit beyond where they're at now to change the process. Now, whether that happens in the guidance aspect, the regulations, or in the actual writing of a law or the issuing of an executive order is something that a group should explore and figure out. But we do have enough evidence on health literacy, shared decision-making, how to create informed decisions among patients in a healthcare context to move that bar forward now. More research is always nice, but not at the expense of actual action. So one thing I didn't hear, which I was very surprised did not come up once, was the inclusion of a group process in an informed consent process. It can actually save a lot of time and money, and also one person's question becomes the group's question. You cannot do the whole process in a group setting, but you can certainly do a lot of it. And in some of these instances, especially in research, it's a time and money saver. I'm just surprised nobody brought that up. And then for the whole day, I sit, as I usually do, and think about it from my health literacy perspective, which first appeared right in the Calgary Charter, and it's a logic model to get people to informed behavior change, AKA informed consent. We're doing very well, I think, at the finding stage and getting information to people. We're doing less well at the understanding stage and making sure that they really do. But the important parts, and this is where plain language never reaches, but health literacy can and should, helping people evaluate that information in the context of their own lives. That's something that most informed consent processes absolutely don't do. Helping them communicate their understanding to their friends and families around them to create a platform for behavior change, that's something that informed consent processes usually never do. And as a result, we really don't achieve a true informed consent because we haven't included those processes of health literacy in the overall effort. And I think that we can and should. And perhaps the way to do that, George started to hit upon it, get people together in a true working meeting, but also the need for the J'accuse document. Isn't that yet again more of an argument to revisit the now 10-year-old IOM initial report on health literacy? And maybe this is the issue that will create some resources to support such an effort. I hope so. Oh, and shout out to Twitter. There's been a lot of talk about this all day on Twitter. So keep it up, folks.
I think you have a theme for this year, Andrew. Laurie?
Thanks again to everybody, and I'll feed off some of Andrew's comments and some of the comments that have occurred along this side of the room. I do want to, this is the first time since I've been involved, I think it's been about 2 years now, that I've heard so much about patient priorities and patient voice. And I think it's because the idea of informed consent is at much sort of more shrill, fearful, fear-based thinking on the part of healthcare, so that when we're talking about oral health or medication management, we're not as concerned or aware that there's a human on the other side of that. But somehow informed consent pushes us to that conversation, so I'm really happy about that. And to feed off what George said in at the beginning of this round, the idea of a new mental model, I think we are getting better at nesting health literacy in the context of human-to-human interactions. But I would say this is the first day I've heard that almost on the part of every panelist. And so how exciting that is for me. And really the palliative care is interesting, how good they are at patient-centeredness. I would say the same thing with behavioral health. They actually get that humans control their own bodies and choices, and that we in healthcare can't convince people, although we do it all the time, try to do what we want them to do. So I just want to pick up on a few themes very quickly. So we heard patient-centeredness, we heard activation. We talk a lot about patient activation, but in fact what many of us have talked about for years is team activation or researcher activation, that until we understand what the person with whom we are engaging wants and needs in their lives and how our conversation fits with that, I think we've missed the boat. And so I would say testing, I would say a leverage area for testing is to test us. Test us if we understand what the priority is of the person we're sitting across from and how this informed consent fits within their priority. And I really think we would move the world with that test. I think that is a big leverage area. And I've watched it in our former health center we did, my former health center we tested patients for health literacy. And we didn't test them because we wondered about their health literacy. We knew it. We tested them because we needed the staff to understand where people were. And so I think if we tested ourselves, we'd all of a sudden have an aha moment. And then I would say we are a lot of smart people in the room, but we're not as smart as we think. And and I think that to change our mental model, we actually need different thinkers at the table, bringing ourselves together over and over to try and tweak a system we're pretty comfortable in. Probably won't create the disruptive innovation we need in this world to truly engage people in the way that they can make behavior changes.
That's a great point, and I really hope that makes the summary. Okay, Ruth?
So I was, there's been conversation about shared decision-making and informed consent and shared decision-making, but I thought back to efforts of the Roundtable around first making sure we have the right conversation and having a shared conversation before you have shared decision-making about the content. And it seems to me that we as a nation need to have a shared conversation about informed consent. And maybe they exist, and I haven't seen them or used them, but I would like to. But where's the primer for all of us on what is informed consent? How do I give it? Why is it important for me? Why is it important for my family and my community? And if we really knew that, the way we have 4 questions maybe about some other things that are on the agenda right now, maybe we could begin to have a shared conversation between those that provide and those that need, so that we give and take and understand why we're doing what we're doing. And I think it came out in many of the people who spoke, but I just want to highlight that I think one of the beauties of working on the topic in general is that it hearkens us all to care. And I think engaging in the content and working to make it better does, at the end of the day, get down to caring. And to have a pedagogy or to try to ask yourself if you can teach people to care is a multi-billion-dollar question and about more than dollars anyway. But I applaud those who are engaged in caring and the opportunity to be a part of a conversation with others that works to roll the Sisyphean ball.
Thank you very much. Eloquence, too, at the end of the day. We have two microphones, one at that end and one over there by the coffee pot. So if there's anybody who wants to make a comment from who's here with us in the room, this would be, please step to the microphone and identify yourself and make your comment.
Chris Trudeau, again, thanks for having me here. One of the things I took away, obviously I learned a lot from this process, but I really like George's idea of where do we go from here in kind of creating the systems approach to informed consent or really getting the right stakeholders involved to hash out a system which might help me answer Bernard Dreyer's question from earlier. How do we create informed consent for these rare occasions where there's not going to be any type of a pre-printed form? I think we can come up with a system for various categories from the community-based approach to clinicians to various treatments, and you can even have them categorized in various by various risk levels. But you need to get the right people involved, not only all of us, but maybe some more lawyers. So I'm not the only voice in here, but patients, obviously, and people along the end of the spectrum. And I think that would be a good start to advancing this in the future.
Make my day, a lawyer making a comment like that. I mean, it's great. And I think very seriously, if you had sort of an IHI type of process where you sat down and really tried to figure out who really needed, what the process was about, who it was serving, what the outcomes were, and then really looked at what everybody has to get from the process. What do the lawyers need to get in order to protect their clients? What do the patients need to get in order to understand what's going on? And how does it need to be presented? What do the doctors need, and so forth? Right on down the line. That kind of exercise could benefit. So thank you again for reinforcing that point. Anybody else? Would you like to? Alicia? I'm sorry.
Thank you. Someone else? No.
No, please go ahead. Please identify yourself.
Alicia Fernandez, UCSF. I want to thank you all for convening this group, and I wanted to encourage you to do the important, to continue the important work that you're doing. Let me say this. I want to make a comparison between change is very slow. For example, the science of washing your hands to prevent, for physicians washing your hands to prevent germs, is more than 100 years old. When I was a medical student in the Bronx at the height of the HIV epidemic, we did not wash our hands. We used gloves, but we didn't religiously wash our hands. Some attendings did, some attendings didn't, and some of us did, and some of us didn't. Right now, in my hospital, and throughout our 3 hospitals, everyone washes their hands, led by the medical students pushing the thing as they go into the wards. What happened? Lots of things happened, including publicity, including putting the location in lowering the activation energy, putting the location in every ward, probably changing the soap, educating the students, leadership from below, metrics, some hand washing. That took a very long time. I think that you are a change group. I think that informed consent is harder than washing your hands, because I do think that there are actually entrenched interests in a certain way that around informed consent, in so much as that informed consent may lead to less procedures. In most of the studies, informed consent leads people to say, actually, I don't want that. And that may be problematic in our current, under our current healthcare system. But there are also plenty of just chaos around it. You are such an important group. If you shine a spotlight, other groups will follow. If you say informed consent matters and we need to look at literacy and language and all the issues that were raised here today, perhaps the AAMC will consider it a core competence in communication that that medical students should learn to do informed consent, and that should be a measurable core competence for every medical student. Perhaps the residencies will do that. Perhaps we'll get leadership from below. Perhaps we'll get other forms of lowering activation energy. What you do matters a great deal. And I want to thank you. You're such a serious for the outstanding leadership that you have already shown on this question. Thank you very much.
Well, thank you so much for that comment. Really appreciate that. Anybody else who would like to ask a question or make a comment? He's moving to the microphone. All right.
Quick and easy. Might be slightly encouraging. My name is David Torres. I'm from the Maximus Center for Health Literacy, and I am an attorney. So I just want to let you know there's more than one of us around fighting the good fight.
Two. So it starts with one, and then it starts with two. So, so thank you for identifying yourself. Anybody else? So it falls to me to do a couple things here at the end. One, I want to thank you. I want to thank each and every one of you for the contributions you've made to the discussion. That's the richness of the dialogue process. Alicia said it very, very nicely for us, and the fact that we're taking this topic seriously and debating it back and forth and surfacing ideas and drawing attention to it is really important. I want to thank the Planning Committee for the outstanding job that's been done in putting together this workshop. I want to thank each and every presenter, even though many of them are unfortunately probably on their way back, for the effort that you've put into your presentations. I can't recall a workshop that I've been to that has had such high quality uniformly across the presentations. I mean, it's been absolutely outstanding. And I would be very remiss if I didn't point to Melissa French, who's not in the room. Where are you? They're applauding before I even say anything. And yeah, really. And she should, because she's done a really wonderful job of spearheading the effort to put this workshop together. We also appreciate Drew and Angela, and of course our leader, Lila, in terms of the IOM team. Have I forgotten anybody on your team at all? So the support that we've had for doing this has been terrific.